Hello, thank you for joining the ERJ Podcast. My name is Dr. Don Sin. I'm the Deputy Chief Editor of the European Respiratory Journal. Today I'm joined by Dr. Marianne Soendergaard to discuss her latest paper entitled Optimal: Titration of anti-IL-5 Biologics in Severe Asthma, an open-label randomized control trial. This paper is published in the August issue of the ERJ. Dr. Soendergaard is a clinician scientist with a special interest and expertise in severe asthma. She's currently working at the Bispebjerg Hospital in Copenhagen, Denmark. Hello, Marianne. Many thanks for joining us today.
Thank you, and thank you so much for inviting me. I'm happy to join.
Could you provide a brief summary of the Optimal study and its main findings?
Yeah, so the Optimal study is a study where we look into the concept of titration of biological therapy for severe asthma, in particular titration of anti-IL-5 therapies. So what we did was that we included patients who had gained complete control of their asthma on an anti-IL-5, and then we randomized them to either have their interval dosing titrated or continue their biologic as normal. And we did the titration not by altering the dose, but altering the intervals between when doses were given. So when patients had full control of their asthma, we would prolong dosing intervals. So we would have a longer time go by between the injections. And if at any point there were signs of loss of disease control, we would shorten the intervals again in order to increase treatment that way. And in the Optimal study, we found that the majority of patients who underwent titration were actually able to tolerate titration to some degree. We saw that 78% of patients, they tolerated titration, and some were even able to completely come off their anti-IL-5 biologic when measuring according to the titration algorithm that we made for this study. We also looked into patients having exacerbations, which would, of course, be our main concern when withdrawing biological treatment. And we compared that to patients who continued their biologics as normal. And what we found that was a fairly larger part of patients in the active arm who had their intervals titrated experienced an exacerbation during the study. So in the active arm, it was 32% of patients. And in the control arm, it was 18% of patients who experienced an exacerbation sometime during the study. When we did Kaplan-Meier analysis to look into time to the first exacerbations for patients between the two groups, we observed a trend towards patients in the active arm experiencing exacerbations during the final part of the trial, where they trialed a period with cessation of their biological treatment. So they didn't necessarily exacerbate when they had intervals prolonged. However, there was a trend towards exacerbations when biological therapy was completely withdrawn. And at the same time, we saw that lung function stayed stable when comparing between the two groups throughout the study, and the same did symptoms.
Normally, when we think about asthma therapeutics, we think about escalation rather than de-escalation. What motivated you and your group to perform this de-escalation or gradual withdrawal study?
I think you're completely right that normally we think about escalating treatment because patients aren't necessarily in control. But actually, after introducing especially anti-IL-5 biologics in our clinics, we found that we actually experienced the opposite problem. So our patients had really wonderful effects from anti-IL-5 biologics. And all of a sudden, we have quite a large proportion of patients who are completely in control. And they've been on a biologic maybe sometimes for years. And we ask ourselves, and oftentimes the patients also ask us, what do we do now? Do we just continue for the rest of our lives? Or do we stop treatment? Or how do we approach this? And there really isn't that much knowledge about how to proceed after sort of control is achieved. We know a little bit about what happens when you stop a biologic, and that's mainly from observational studies on patients who participated in phase 3 trials. And when we look at that overall group, we can see that these patients, they tend to lose control. They go pretty much back to their baseline after 3 to 6 months. So that sort of gave us the idea that probably maybe abruptly stopping treatment wouldn't be the best idea. But certainly there's a prolonged effect from treatment that goes beyond the sort of prescribed treatment intervals. So we figured that probably the best approach would be titration, where we would prolong intervals gradually in order to identify sort of how much treatment the individual patient would need.
So to personalize therapy, you conducted this study. Now, assuming a patient can stop the biologic, would that lead to better outcomes in terms of health economic outcomes or health outcomes? Or what's the advantage for the patient to withdraw completely from a biologic?
I think for the individual patient, I think it's always an advantage for everyone to need as little medication as possible. And I think when you look at it from a sort of a health economic perspective, I think what we see more and more with biologics is that the sooner you are able to initiate a biologic, sort of the better the outcome is. And of course, the problem with biologics is that they're wildly expensive. It depends from country to country and guideline to guideline, but you have to be fairly ill to even be a candidate. So hopefully with the optimal study, we're able to show that it could be possible to maybe not completely come off the biologic, but certainly to taper the biologic in order to make these drugs available to more patients. Because I think more patients need them than patients are currently actually receiving them.
Now, it's been several months or maybe a year or two since you stopped the optimal study. Of the patients that you studied, do you have any sense of where they are at today? Were those who stopped therapy still off therapy? Or have many of these patients gone back to the biologics or different biologics?
Well, I would say that I don't have a complete overview of all the patients who participated, but I know of a few patients who are still off the biologic. And I know a few patients who are back on a biologic. And of course, we do quite a lot of switching often in time. So some patients have been switched as well. But my impression is that the majority of patients who tapered their biologic, they're still on a tapered dose.
A tapered dose, a lower dose, or
yeah, exactly. So
less frequent dose, I should say.
Yeah, a less frequent dose. Because what we saw in the optimal study is that I think fairly few patients were able to come completely off the biologic. And I think when we look at when patients were exacerbating, it seems that more patients exacerbate during a trial period of cessation. And I think the majority of patients in the active arm actually trialed cessation of treatment, but very few of those actually tolerated it. So I think when we move forwards with this concept of titration of biological therapy for asthma, I think the focus should be on tapering the biologic, but not necessarily withdrawing the biologic completely. Because I think certainly some patients are able to come off it, but it's a minority. And I think we need to figure out a nice way to identify these patients, which probably isn't just taking the drug from everyone and see how it goes.
Yeah, that's, I think, a brilliant observation. One thing I found kind of peculiar about your study was that only a third of patients were females. I thought in severe uncontrolled asthma, females predominated over males. Can you comment on that?
Probably the main reason would be that I think maybe males tend to do a little bit better on a biologic. I think when you look at the overall group of patients with severe asthma, there maybe are a few more men who have severe and clearly T2-driven asthma who would be candidates for biologics. But I think certainly in Denmark, the proportion of patients initiated on a biologic is 50-50. We did a study where we looked into patients who achieved a complete response to biologics, which is them not having exacerbations anymore, not having to be on maintenance oral corticosteroids. Those are the patients who would essentially be candidates for the optimal study. And of those, not a big majority, but a majority of them were male.
That's very interesting. What lessons did you learn from the optimal study, and what would you do differently designing the next study in this field?
We already are having some thoughts about the next studies, and I think the next studies, it probably won't have the part of withdrawing the biologic completely, but it will focus on tapering of the biologic. And I think in the optimal study, you could either have intervals prolonged by 50%, or you can have them prolonged by 125%, or you could have treatment withdrawn. And I think maybe it would be helpful to sort of make smaller boxes so that we're able to individualize the tapering even more according to individual patients' needs. So not just sort of the only two categories, but having them be adjusted sort of in a more delicate way.
Okay, that makes a lot of sense. So lower dose rather than complete cessation would be the optimal aim for the next optimal study.
Yeah, definitely.
Do you have any last words on the optimal study or regarding severe uncontrolled asthma in general that our audience should know about?
I certainly hope that the optimal study will contribute to us looking at treatment with biologics in a more nuanced way. And hopefully it will also be the first step in making biologics more available to patients worldwide, with us being able to show that it is taperable, if we could say that word.
Yes, we can. Yes, I think maybe on that very, I think, optimistic note, we'll end our podcast. Thank you again, Marianne. Thank you for joining us today. Dr. Soendergaard's paper, Optimal, Titration of the anti-IL-5 Biologics in Severe Asthma, an open-label randomized controlled trial, is now available on the ERJ website, erj.ersjournals.com.